Hi class, this is an online lecture on IV therapy and we will be discussing total parenteral nutrition, TPN, and IV medication math formulas. So parenteral nutrition, known sometimes as PN, is the delivery of nutrients directly into the bloodstream, bypassing the digestive system, and it is typically used when patients cannot eat or they cannot tolerate enteral tube feedings. So this presentation will cover key components for TPN, rationale, nursing care, safety guidelines, and communication, as well as documentation expectations. So principles for parenteral nutrition. Peripheral parenteral nutrition can be used for patients with mild to moderate malnutrition. So what that means is that peripheral parenteral nutrition is less concentrated than a central line total parenteral nutrition because peripheral veins can't tolerate high osmolarity solutions that are often required in TPN. So sometimes PN is used, which is a milder version of the nutrition, and you can use these smaller veins short term for like 5 to 7 days who for patients who need nutritional support but do not require the full high caloric TPN. So the goal is always to provide the nutritional requirements to our patients while minimizing parenteral nutrition related complications. So the nutrition bypasses the GI tract entirely. So as the nurse, you must be vigilant for complications such as infections, catheter related sepsis, electrolyte imbalances, hyperglycemia, and fluid overload. It's really important that as a practical nurse, you use aseptic technique during tubing and dressing changes. And lastly, the type of catheter used depends on patient factors and the expected length of PN therapy. So, like I said, you need a central venous access, such as a PICC line or a tunnel catheter, for total parenteral nutrition because the solution is highly concentrated and has a harsh osmolarity and must be infused into a large high blood flow vein. Short-term therapy may use a PICC. Long-term therapy may require even a tunnel catheter or a portacath. Factors that may influence the catheter choice include the duration, the venous access quality, risk of infection, overall health, and making sure they have the correct line for parenteral nutrition improves safety and reduces complications for the patients. So now we're going to talk about the contents, and I'm just going to grab a little highlighter down here so I can do some visuals for you. So when we talk about parenteral nutrition, we're really referring to a complete nutritional formula that is being delivered directly into the bloodstream, okay? So because the GI tract is completely bypassed, everything the body needs must be included in this parenteral nutrition solution. So in this solution, it is essential that all the nutrients are in it to maintain or restore a person's health. So carbohydrates are the primary source of energy in the parenteral nutrition, and dextrose is the primary carbohydrate, which is why we need to check blood glucose levels to assess for hyperglycemia when someone is on TPN therapy. Next is proteins and amino acids. So they provide essential building blocks for tissue repair, um, immune function, and wound healing. Amino acids are especially important for the surgical patients, trauma patients, or anyone who has increased metabolic demands. There are electrolytes in the parenteral nutrition, and that is to maintain fluid balance and cellular function. And because there are electrolytes in the TPN, it is necessary that frequent blood work is being drawn and monitored because these electrolytes may shift quickly whenever parenteral nutrition is being delivered. There are trace elements and vitamins added, and these support metabolic processes. Trace elements are needed in very small amounts but are essential for enzyme activity and metabolic functions. The trace elements are things like zinc, copper, selenium, chromium, and deficiencies can develop if they don't include these, especially if someone is getting long-term parenteral nutrition. Multivitamins are added as well, and these support immune function, wound healing, and overall metabolic processes. Lastly, lipids may also be given, not always, but they may also be given. And lipids provide essential fatty acids, provide additional calories, and they are sometimes administered separately from the rest of the nutritional elements. So they could be included in a 3-in-1 bag that has separate chambers, or administered as a separate infusion altogether, depending on the facility and the patient's needs. You do need to monitor your patients for their lipid tolerance or intolerance and allergies, especially in patients with liver disease or liver failure. So this slide focuses on why we use parenteral nutrition, what the clinical reasons are for bypassing the GI tract, and giving nutrition directly into the bloodstream. So PN is mostly indicated for patients who cannot meet their nutritional needs orally or through a tube feeding, and the primary indication for parenteral nutrition is when the GI tract cannot be used. And this might be due to things like a bowel obstruction, severe pancreatitis, severe GI trauma, an ileus, Crohn's, exasperation, or colitis. Um, Another reason is to promote wound healing. So critically ill or post-surgical patients often have increased metabolic demands, so this nutrition provides all the protein calories needed for tissue repair, collagen formation, and to support their immune system. Without adequate nutrition, as you've already learned in this course, wounds will heal slowly and infection risk will be increased. Sometimes TPN is used to achieve optimal weight prior to surgery, and some patients need to be nutritionally optimized before they can have their surgeries. So parenteral nutrition can help restore energy, protein balance, strength, increase weight prior to a procedure to again reduce post-op complications and improve recovery outcomes. Avoiding malnutrition related to chronic diseases is another reason why it's used. So chronic diseases like Crohn's disease, ulcerative colitis, advanced liver disease, chronic bowel obstruction can lead to long-term malabsorption issues. So this helps prevent muscle wasting, weakness, and immune suppression in these clients. And lastly, and probably one of the less common reasons why parenteral nutrition may be needed is to treat cancer cachexia, which is a wasting syndrome where cancer patients have severe unintentional weight loss due to the high metabolic demand and their decreased intake. So this can help support nutritional needs when eating becomes difficult for many reasons. It could be like severe nausea, there could be digestive issues, and so forth. So So this is an important slide because this is the nursing care of the patients receiving parenteral nutrition. So the initial ongoing assessment when someone has TPN running is to monitor the blood glucose regularly, and this is due to the risk of hyperglycemia because of the glucose in the solution as the main carbohydrate. We also want to track daily weights to evaluate fluid balance, weight gain or loss, and nutritional status. We want to be diligent about watching for signs and symptoms of infection like fever, redness, tachycardia, redness at the IV site, pain, feeling unwell, all the normal signs of infection. You want to initiate TPN slowly and increase gradually to decrease the risk of metabolic complications. So you want to provide person-centered care for someone receiving total parenteral nutrition, and the nurse is going to include the patient and family in decisions to maintain the patient's control, their activity level, their decision making, and their socialization with their family members and their friends. Okay, so that's including patient and family in decisions. We need to collaborate with nutrition support teams and multiple healthcare providers in the administration of parenteral nutrition. Although, depending where you work, it may vary, but typically you're going to need dietitians and pharmacists as well as a physician to come up with the formula and the um, procedure on the nutritional support. Um, there will need to be an order for the parenteral nutrition, and this will be created in collaboration with the dietitians and the pharmacists and the nurses, and there will be a policy wherever you work to give TPN safely, so you're going to follow that policy very closely. If you ever have any questions, concerns, call the pharmacist or talk to the dietitian. Pharmacy is who will supply the TPN up to the floor and formulate it, but the dietitian will help figure out what is needed. So next is monitoring the electrolytes. We already discussed this, but patients who require PN infusions usually do for medical surgical conditions that are often associated with GI losses, organ dysfunction, and they're also getting electrolytes in the solution. So electrolyte monitoring is paramount. So typically you want a laboratory panel, and this would include a baseline of their blood work with electrolytes, their proteins, CBC, triglycerides, and liver function tests. And this is all to prevent imbalances. You need to document patient progress, monitor intake and output, monitor vital signs as per the policy or the physician's order or the healthcare provider's order. And you need to respect cultural and philosophical beliefs and patient care choices. So parenteral nutrition solution is typically provided in response to some kind of GI problem, and it is important that we listen to the concerns of groups of people who may have beliefs. It could be religious beliefs, ethnic groups, or philosophical beliefs that include restricting animal products such as pork, or vegans may not want any eggs. So the components that are within parenteral nutrition are largely synthetic. So made up artificially, and they do not contain any pork. However, the lipids do contain egg and So this may be a problem for some patients. If there are concerns about the contents in the TPN and you are unsure uh, on how to guide the patient and their family, you could certainly uh, collaborate and refer them to the pharmacist and the dietitian to answer those questions specifically. TPN safety guidelines, I do think I've already covered a lot of this, but we'll quickly go through them. So you need to have appropriate care of the vascular access device, dressing, and site to minimize catheter-related bloodstream infections. So number one, we don't want to cause a blood infection in our patient getting TPN. So we don't want to be drawing blood off of their IV or interrupting the infusion. They should most commonly have a PICC line or a central venous access device. We should always make sure that central venous access device has been confirmed by X-ray. We always need to use aseptic technique when we're handling the IV and any equipment, and during the dressing changes and tubing access. And if you are using a short peripheral IV line, it should only be used for very short-term situations where they're getting low calorie requirements, and I already talked about that. So it should not be infused into a short line or a midline, only if it's for very short term and it's not a high caloric solution. All right, there's more safety guidelines. And many hospitals use PICC lines for parenteral nutrition, and I already talked about making sure that you have it confirmed by an X-ray and using appropriate aseptic sterile technique when you are handling the tubing and the line and accessing the caps. So although parenteral nutrition without lipids can be infused using tubing with a 0.22 micron filter, a larger micron filter, 1.2, is needed when you are given lipids. So this is to prevent particle infusion. So my point here is that you need to use filtered IV tubing when you are given TPN, and you need a larger filter if you are given lipids. You want to ensure that there's adequate electrolyte replacement prior to initiating parenteral nutrition to prevent imbalances. And because there is a risk of bloodstream infections, regularly monitor the temperature of the person who is receiving the TPN. So here is a picture of the filtered tubing, and this is the filter here. I do have some of this filtered tubing on campus in the lab that I can show you, and it will say on the bag whether it is 1.2 or 0.2, and I can show you that as well. So it will have a cartridge that looks like this, which is the filter. The tubing basically looks identical to the primary IV tubing that you are familiar with, except it has this rectangular typed filter, and it will say filter tubing on the package. Communication and documentation for parenteral nutrition. So you need to accurately document the IV site condition, the type of solution, the infusion rate, the status of the infusion, the patient's response, intake and output, blood glucose levels, vital signs, and patient weights, and any other assessment findings or adverse reactions. You need to report any signs of intolerance immediately, such as infection symptoms, fluid retention, or occlusions. If signs of intolerance, infection, occlusion, or fluid retention, notify healthcare provider promptly. So calculating IV rates, we're going to change focus here, okay? So that's everything for total parenteral nutrition. We're now moving on to our IV med math. So we are going to review the 3 core IV math formulas used in clinical practice. So the first one up here is our infusion rate, so mils per hour. Then down here we have infusion time, so sometimes you want to know how long it's going to take to administer a bag of fluid. And then down here we have our drops per minute, which is used to calculate how many drops per minute need to flow, and that is whenever you're using gravity instead of an electronic infusion pump. These 3 calculations will appear and be used consistently across all skills textbooks and are essential for safe IV medication administration. Everything you do with IV med math connects back to making sure the client is receiving the correct dose at the correct time using the correct device. Whether we're talking about an IV pump or a gravity flow rate or a peripheral line or a central line, errors in the rate or the timing or the site can have major consequences and safety issues, especially if you're given medications like potassium, heparin, insulin, or antibiotics, or narcotics. So precision and your math calculations matter a lot. So these formulas are pretty easy, and you certainly need to know them. So the first one is your how much volume is going to be administered every hour. And all you do for this one is take your total volume in mils. So if you have a 1,000 ml bag and you divide it by how many hours. So for example, if you have a 1,000 ml bag and you are going to hang it for 10 hours, then you would know that your rate is 100 mils per hour. Okay, so if we had 1,000 ml bag, which is quite typical, and you are going to hang it for 10 hours, 1,000 divided by 10 is 100. So the answer is 100 mils per hour. Okay? Sorry, it's very hard to type in here and I don't have a mouse at the moment. The second formula is how long will it take to administer the total volume. So sometimes you want to know, is this bag going to take 8 hours or is it going to take 2 hours to go in? And again, this is a very simple formula. You just need your total volume in mils divided by your rate, your mils per hour. So let's say we have a 100 ml bag. Okay, so we have 100 ml, say it's antibiotics. It's a 100 ml bag and it is going at, let's say, 150 per hour. It's going pretty fast. Okay, 150 mils per hour. Sorry, this is so slow. Then we just take 100 and divide it by 150. So you can all do that with me. And you will get 0.66, and that is 0.66 of an hour. So, okay, so that 0.6666 rounds to 0.67 hours. And I know I made this a bit tricky because I did such a fast rate, but anyway, 0.67 hours. To figure out how many minutes that is, you're going to times it by 60 minutes, and that will give you 40, so it would take about 40 minutes for this bag to infuse, which if you look, that makes sense, right? 40 minutes. So I'm going to just write the answer here. It's going to take 40 minutes for that to go in, and I'm going to show you why that makes sense in a second. So I told you you had a 100 ml bag, and it's going at 150 mils per hour. So if it was only going at 100 an hour, it would take 1 hour, but it's going at 150 mils per hour. So it's going to go in faster than an hour, which the answer works out to about 40 minutes, which is 0.66 of an hour. So the answer was 0.66 of an hour. And when you times 0.66 by 60 to figure out how many minutes, it works out to 40 minutes. I shouldn't have did such a confusing example. I apologize. And then lastly is your drops per minute, which you already know this, I believe. So your total volume in mils, which you will either have given to you or you can figure it out. Keyword here is total volume in mils times by the drop factor. The drop factor will always be provided to you on the IV tubing bag, and you're going to divide that by the total time in minutes. Okay, which again will either be given to you or you can figure it out quite easily by doing a quick math calculation. All right, so let's practice. Your patient needs 1,000 mils of fluid over 8 hours. What is the flow rate, mils per hour? Total volume in mils divided by time in hours. So here you're just going to take 1,000 mils, so plug that into your calculator, divide it by 8 hours, and you all should get the answer of 125. And when we're talking about infusion rates, we're always talking about mils per hour. And I really do not enjoy writing on this because my finger is cramping. Okay, so very simple. Volume divided by time in hours. Next is infusion time, which we just practiced. So your patient requires 500 mils of normal saline. So picture a 500 ml bag of saline, and it's going at 80 mils every hour. So what's the infusion time, first of all? So that's your first question. And then the next thing it wants you to figure out is if this was hung at 5 in the morning, what time is this bag going to be empty? So for this, you are going to take your total volume in mils, which is 500, and, oh, sorry, excuse my poor penmanship, 500 divided by 80, which equals 6.25, okay, 6.25, and that 6.25 is talking about what? Is it talking about mils? No, it's talking about 6.25 hours, okay? So the next thing you have to ask yourself is how much is 0.25 of an hour? Well, there's two ways you can do this. You can take, like I said earlier, 0.25 and times it by 60, because it's 60 minutes, and you will get your answer, which is 15 minutes. Okay, so 6 hours and 15 minutes is how long this is going to take to go in. And also 0.25 of an hour. Another way you can figure this out is by looking at the clock. So 1/4 is 0.25, so that's 15 minutes. Another quarter is that's 0.50, half of your clock, right? 0.45 would be 45 minutes of your clock, and then your whole 60, right, would be 1 hour. So when you think of 0.25 of an hour, think of 1/4 of the clock, which equals 15 minutes. So the infusion is going to run for 6 hours and 15 minutes. But my question is asking you, if this is hung at 5 a.m., when is it going to be finished? So 5 a.m. and we need to add 6 hours and 15 minutes on that. So 6 o'clock, 7 o'clock, 8 o'clock, 9 o'clock, 10 o'clock, 11 o'clock, and then add your 15 minutes. This will be done at 11:15 a.m. So hopefully that makes sense. And lastly is your drip rates. So determine the drip rate for a solution with a flow rate of 125 mils an hour when using a set with a drop factor of 60 drops per mil. So your formula for this is your total volume in mils times by your drop factor, which will be always given to you on the bag, divided by your total time in minutes. So this formula will only ever be needed when you're using gravity IV infusions, not when you have an electronic infusion pump. This drop factor number will always be printed on the IV tubing package, and the most common ones are going to be macro drips, which are usually 10 drops per minute, or per mil, or 15. These are your macro drip rates that are typical, 10 and 15. And then a micro drip would be a bigger number, 60 drops per mil. And micro drip tubing is good for patients that need very precise volumes, like a pediatric client or a critical care client. And so for this flow rate of 125 mils per hour using a drop factor of 60, and we're trying to find drops per minute, so you would take your total volume of fluid, so all you know is the 125 mils per hour, so you'd put 125 here, and then you would times that by your drop factor, which is 60, and then you would divide it by your time in minutes, and all you have is 1 hour, so that would be 60 minutes. And I'm just going to I think the answer will pop up here when I flick the slide, but some clinical safety points is you can't count partial drops. So for your answers, I never want to see 22.2 or 22.6. You're going to round to a whole number. You cannot count a quarter of a drop or 3/4 of a drop. So you need to round your answers. Also, always make sure your drip chamber is filled appropriately to where it is supposed to be, and recheck the rate frequently when you're using IV gravity because it can change, or someone could play with it and change the drop factor. So I did flick the slide here, so 125 times by 60 is 7,500, and then that needs to be divided by 60 minutes, and your answer is 125 drops per minute, which you would need to eyeball and count, visualizing 125 drops dropping every minute, and that is a macro drip. That's a macro drip drop factor. Okay, so here's another practice one. Mr. Simples to receive 500 mils of normal saline over 4 hours. You have tubing that delivers 10 drops per mil. How many drops per minute is this? So I will let you take a few minutes to work this one out, and then we'll talk about the answer on the next slide. Remember, you need to round to a whole number. I don't want any decimals in your drop factors. Because this is macro drip tubing, 10 drops per mil, the number should look reasonable and not be extremely high, like 125 like you just had. Micro drips will have higher drip rate numbers. Macro drip are going to have smaller numbers. So for Mr. Simple, we had 500 mils of normal saline, and I'm just actually going to get the highlighter here. We had 500 mils of normal saline, so that was our total volume in mils, so 500 times by our drop factor, which is on the bag, and it's 10. So 500 times 10, super easy, is 5,000. And then our total amount of minutes, so we had to take 4 and times it by 4 hours times by 60 minutes. And that 4 times 60 equals 240 minutes. So 5,000 divided by 240 is 20.83 and drops per minute. And then I told you you have to round this number, and that is where we get our final answer of 21 drops per minute. And that is a small number that you would count over a minute, and you would be looking for about 5 drops every 15 seconds. All right, so you're going to practice on some worksheets. I have lots of worksheets I'll hand out. Always confirm the drop factor. That's the #1 rate mistake. For time problems, remember to convert your decimals. 0.25 of an hour equals 15 minutes. 0.5 of an hour equals 30 minutes, a half an hour. And 0.75 hours is 45 minutes. If something feels off, always do your mental math estimation. If you're giving a bag of 500 mils at 100 mils per hour, you know that would take 5 hours, hopefully. 500 divided by 100, 5 hours. So if it's going at 80 mils an hour, you should know that that's going to take a little bit longer than 5 hours, a little more like 6 hours. So that's your mental math whenever you're looking at your pump or doing gravity flow rates, is to always be seeing if things feel off and if they make sense. That's it for today. Thank you.